There are many ways to classify skin and soft tissue infections.
This can be based on factors like where the infection occurs, such as folliculitis, fasciitis, or myositis, how long it lasts, acute or chronic, whether the tissue is dying, necrotizing or not, if pus is visible, purulent or non-purulent, or if it affects deeper tissues under the skin. Recently, the FDA introduced the term acute bacterial skin and skin structure infections to describe conditions like cellulitis, erysipelas, wound infections, and major skin abscesses, as long as the infected skin area is at least 75 square centimeters. In this video, we will focus on mild forms of skin infections that only affect the surface layers, impetigo, erysipelas, and cellulitis. First, let's talk about the causes and common pathogens involved in skin and soft tissue infections. When the skin is damaged, it can lead to infections in the deeper layers below the outer skin. Both pathogens that naturally live on the body, and those that come from the outside, can enter the skin and spread deeper through the lymphatic system. Depending on how deep the infection goes, different conditions can develop. For example, impetigo and erysipelas affect the top layers of the skin, while cellulitis reaches the deeper layers like the dermis and subcutaneous tissue. The most common pathogens causing skin infections are Streptococcus pyogenes, especially in erysipelas, and Staphylococcus aureus. In people with weakened immune systems, diabetes, or skin injuries, other bacteria like Enterobacterales and Pseudomonas aeruginosa, including drug-resistant strains such as ESBL and carbapenemase producers, are often responsible.
Anaerobic bacteria can also cause these infections. Before getting into details, let's learn about the morphology of different skin lesions. Bulla, a large blister filled with fluid, more than 10 mm in size. Vesicle, a small fluid-filled blister, less than 10 mm. Papule, a small raised bump, less than 10 mm, that can be felt. Pustule, a small bump, less than 10 mm, filled with pus. Impetigo is characterized by acute onset of superficial skin lesions. In most cases, impetigo presents with papules that progress to vesicles and pustules which break to finally form crusts. Non-bullous form in a minority of cases. Mostly in young children, vesicles develop to form larger bullous form. Erysipelas is characterized by acute onset of a red skin lesion with well-defined indurated
margins. Bulli may be present or develop in the first few days.
The lesion is usually painful.
Fever, greater than or equal to 38.0 degrees Celsius, and other signs of systemic
infection may be present. While erysipelas affects only the superficial skin layers and has clearly demarcated borders. Cellulitis also affects subcutaneous tissues. Cellulitis is characterized by an acute onset of
a skin lesion presenting with a combination of redness, swelling and induration, warmth, and pain of the affected area. The condition can occur anywhere on the body, but predominantly affects the skin of the lower part of the legs and feet or the face. Facial and neck cellulitis can sometimes result from a dental infection spreading locally. If not treated, this can lead to severe infections in deeper areas, like Ludwig's angina, which can be life-threatening, or even spread to the brain. In most mild cases of impetigo, erysipelas, and cellulitis, routine microbiology tests aren't necessary. However, swab cultures can be useful in specific cases, especially if there is obvious pus. When taking a sample, the area should always be cleaned and the dead tissue removed to make sure the test identifies the bacteria causing the infection, rather than bacteria that are just present on the skin. Now let's talk about treatment. For localized non-bullous impetigo, it's better to use topical treatments instead of oral antibiotics. A 5-day treatment with mupirocin 2% ointment is one common option. Other alternatives include fusidic acid or hydrogen peroxide cream, 1%. For widespread impetigo, erysipelas, or cellulitis, oral antibiotics are the preferred choice. The treatment is generally the same for both adults and children. Options include amoxicillin plus clavulanic acid, cephalexin, or cloxacillin, usually for 5 days. In children, the dosage needs to be adjusted based on their weight. And with that, our video comes to an end. Thank you for watching, and we wish you a healthy, peaceful life.